I see the problems are in Ukraine, but you're much better at judging the problems in Ukraine than I am. Next slide. So, what is the perfect ideal training? Well, first of all, it's clinical experience, not theoretical book learning. You learn medicine, you learn operating, you learn physical, you learn medicine, whether it's kidney disease or neurology or whatever. You learn it by seeing patients, seeing their problems, and combining that with book learning and online learning. It is much easier now than when I was a young doctor because there is so much on the internet. I had to go to the library, look for journals and books, and usually they were not there. So it is much easier now to have all the information. But it must be based on actual clinical practice. We learn most from patients, not from books. You need to have senior, experienced doctors who are interested in teaching and training and committed to it. And that is difficult if, as is often the case in many of the countries I've worked in, you see senior doctors see a problem with teaching junior doctors that they will end up being in competition with them. They do not want to share their secrets. And you need to select trainees, young doctors, on the basis of a competitive examination, not on the basis of bribery or who your father is, if he's the head of the professor in the department. You need a structured program. There are definite stages to the training, and at each stage it is quite clear what the young doctor is expected to know and what he is able to do, and if he or she has not reached that stage, they have to repeat it or go back and repeat some of it, and they do not move on to the next stage until they have completed the previous one. And certainly now in America and Britain, I'm less certain about Europe, we are not allowed as senior doctors, we are not allowed to bully our trainees, and sexual harassment, which is still a problem in England. There's been a lot of discussion in the media recently about young women doctors being hit upon, bothered by other doctors, men doctors, is increasingly frowned upon, and we are trying to get rid of it. Next slide. Now, in Britain, which is not perfect, but it generally has a good international reputation for training, and I'll talk a little bit about the rest of Europe and America later. For all the different specialties, whether it's family medicine or brain surgery or pathology or psychiatry, it's about 5 to 6 years of training. Some of the specialties, psychiatry, I think is 4 years, I'm not quite sure, but it's certainly much longer than here in Ukraine. After usually about 4 or 5 years, there is a national examination which you have to pass. In neurosurgery it is in 2 parts. One is a very difficult multiple choice question paper, which I would almost certainly fail if I had to take it now. And the second part, if you pass the first part, is 1.5 days of oral examinations, vivas. I did that for almost 20 years. I examined young neurosurgeons, and you sit them down and you say, how would you operate? How would you do this operation? And they have to tell you in words what they would do, and you can tell immediately as an examiner whether this young surgeon actually has done the operation or not. If they're just repeating what they've read in the textbook, it is usually quickly very obvious. And again, the examination is very, very objective. There are always 2 examiners, and they have to behave very politely. And there'll be another examiner who will be examining the examiners. As a senior doctor, I used to walk around the room where all the interviews are going on, making comments and notes about whether the examiners were doing the examination well or not. So it's a very, very accurate and objective system with great care that bias against sex or ethnicity or things like that does not influence the way the examiners are behaving. In England, after you have completed the national exam, and you are only allowed to take it about 3 or 4 times. If you fail several times, then you have to stop. There is then another 1 or 2 years of working as a trainee in the department, and then the government will give you a certificate saying you are now a fully trained neurosurgeon, pathologist, physician, whatever. And then you either, or usually what most people do is they try to find a job in the government health system, because we have a socialized health system where everybody in theory gets free treatment, or you can in principle work purely in the private sector. There are private hospitals and private clinics, but the great majority of private hospitals and private clinics will only have doctors working in them who have full-time contracts in the government system and then work in their own time out of hours in the private hospitals. And again, in almost all the medical and surgical specialties, we all specialize. It is very difficult to find a general neurosurgeon now. I was a general neurosurgeon 40 years ago. I did everything, aneurysms, tumors, spinal surgery, things like that. But now we all specialize. By the time I retired from full-time operating, I only operated on brain tumors. And in general medicine, you'll have a specialist in the lungs, a specialist in the heart, a specialist in the kidneys, or in the endocrine system, or in rheumatic inflammatory diseases. But you'll not have any doctor who deals with all of them, other than a family doctor who does not know much specialist knowledge, but will know which specialist to send his or her patient when necessary. And for instance, in orthopedics, you will now either spend your whole time operating on hips or knees or ankles. It is subspecialized into each joint. Next slide. So as a diagram, so on the left, you graduate from medical school, which is 5 years, or 6 if you do an extra year to have a science degree, science diploma, as well as your basic medical training. You then spend 2 years, called the foundation years, as an intern, doing general medicine, general surgery, taking blood, writing up drugs, looking after the patients at the most basic level. You then will start your specialist training, which is for between 4 and 6 years, and then at the end of it, you have your government certificate. You are now a fully trained, certified specialist. Next slide. And in Europe and America, it's pretty much the same sort of time. What's unusual about Britain, but we need not discuss it too much, is there is no head of the department in the way you have here or in America. It's complicated, but it's more or less a democracy where each of the senior doctors is free and nobody can tell him what to do. But in America, there is always a head of department, and he will hire doctors to work in the department, and he will fire them if they are no good. In England, once you are appointed to a senior doctor position in a government hospital, it's basically a job for life. And it is very difficult to get rid of doctors, and it's very unusual for doctors to be kicked out of the government health system. Next slide. So what are the problems certainly in Britain? Well, there are too many trainees, and they work because despite the madness of Brexit, we still work what's called the EWTD, which is a European Working Time Directive, that nobody should work more than 48 weeks a year, although you can opt out of it. the government in Ireland, for instance, said our doctors are not going to work 48 hours a week, they'll work longer than that. The British government, despite Brexit, still says that doctors only work 48 hours a week, which means you need more doctors to cover all the shifts and rotas, and it means the new young doctors in Britain have much less clinical experience, so it takes much longer to train them to a sufficient standard. And also there can be problems of producing too many doctors. There is a fixed number of senior neurosurgical posts, but for some reason recently we have produced too many trainees. So there are about 70 fully certified neurosurgeons who are, well, they're not unemployed, but they cannot find senior jobs in the hospital system. And if they tried to set up in private practice on their own, they would not succeed. So they have to continue working in a junior role, even though they are fully certified. And in some areas, such as pathology, in particular mental health and psychiatry, there is a lack of consultants. There are not enough trainees going into that profession. Because again, in Britain, all doctors are paid the same. A brain surgeon is paid the same as a psychiatrist or as a pathologist. You get a little bit more money if you're on call at night, but not very much more. So that's a slightly unusual arrangement, but so it is. Next slide. I think in medicine, certainly in management theory nowadays in the West, we try to suggest that true leadership is what happens on the right-hand side. The leader supports the employees. We like the word empowerment. He helps them work better. It is not the dictatorial system where the leader tells all the employees what to do. Obviously in Ukraine you still have a very, very hierarchical medical system, which in my opinion is a mistake, because as doctors we all make mistakes, and other people are better at seeing our mistakes than we are. And if you have an all-powerful professor who never makes mistakes, when of course he does, but he never admits to it, this does not lead to good medical results. Next slide. There is a lot of concern now, particularly in America, but and also to some extent in England, about what is called burnout. The doctors are getting exhausted, overworked, and also there's bullying and harassment. And people talk a lot about this. Whether it really is a big problem or not, I don't know. Doctors have always had high suicide rates, particularly women doctors. I don't know about Ukraine. But one reason for that is doctors have access to effective ways of killing themselves. So it might not be because of the work. But there is increasingly a stress on team working, which is something I very much believe in myself. When I went into neurosurgery more than 40 years ago, I saw myself as a heroic individual. So Beethoven, Einstein, things like that. But now, as I look back on my career, I increasingly see my own specialty of neurosurgery, although I know this applies to all branches of medicine, as a collaborative, cooperative effort. Teamwork. Now, teamwork often means sitting in boring committee meetings and nobody making a decision. But I would phrase it a little differently and say the really important thing in medicine, just as important as a lot of experience, just as important as reading all the literature and knowing a lot of facts, is being a good colleague. If you are not a good colleague, you're not a good colleagues yourself. But if you do have good colleagues, next slide, I think that's the next slide, come back one. The advantage of, if you have really good teamwork, you work together, and it's not just everybody being friendly and nice to each other. It's about constructive criticism. But my colleagues will tell me, Henry, I think you're wrong, and then we can argue about it and come to an agreement. It's about sharing our experience. And I've always felt, and this is what my books are largely about, it is the duty of senior doctors not to say how good they are, but to talk about all their mistakes. It is your duty as a senior doctor to stop the doctors of the future making the mistakes you made. Because medicine is dangerous. We have the lives of our patients in our hands, and it is very important we try to reduce how much harm patients come to when they're under our care. And there is a very large amount of literature now, particularly from America, showing how literally tens of thousands of patients die every year or are left damaged and injured because of medical mistakes. And I've seen every time I come to Ukraine, I see patients where there has been a mistake of one kind or another. It's not that Ukrainian doctors are necessarily worse than doctors elsewhere, but there are no good mechanisms that I can see in Ukrainian medicine where mistakes are recognized, acknowledged, and discussed so they are less likely to happen next time. And teamwork is important for trying to reduce mistakes. It is also important because we work in teams, and that's important for how we treat patients. And there's this fascinating paper which was published recently, which I only heard about last week, of a large study of large numbers of patients where they collected data in an American hospital about how doctors, surgeons behaved towards what we call their co-workers, the junior doctors, the nurses, the porters, the cleaners, people like that. So they collected data, and there was a clear result. But the doctors where there were many complaints about their behavior, co-worker reports saying this doctor is rude and unfriendly, their patients had more complications. Which we think about it, well, that's very interesting. And there are two possible reasons for that, of course. One is that if you work for a doctor who is a shit, you'll be rather less likely to look after their patients as well as you should. And it's also possible that doctors who treat their co-workers in a shitty way will also be less good at looking after their patients. But there's a lot of evidence that, the way we behave as colleagues is a very, very important part of trying to have good medical results. We must get away from the view of medicine which I had when I went into the profession, and certainly the view of the surgeons who trained me, that I was a heroic, glorious individual who never made mistakes, and if I did make mistakes, I always carefully denied them or hid them. Next slide. So why is teamwork so important? I've already said some of this already, but I'll repeat it. Firstly, yes, next. My colleagues are better at seeing my mistakes than I am. All of us find it very difficult to think badly about ourselves. There's a lot of psychological research on how we fool ourselves about how good we are. My colleagues will see my mistakes better than I can, and I'm better at seeing their mistakes. And if we are good colleagues, we will criticize each other, and therefore we will be less likely to harm our patients. Next. It's better for your mental health. Medicine can be very, very stressful, particularly in Ukraine at the moment, at the front line, with all the war injuries and children horribly damaged by shellfire and bombs. So it can be very, very stressful. And yet the fact is, from my own experience, only your colleagues understand how difficult it can be. Most surgeons, I think, not all, I can't speak for Ukraine, it's strange, but whenever my patients did badly, I felt terrible about it. I went on working. After a few days, I sort of forgot it. But even though now I'm partially retired, I'm surrounded by the ghosts of former patients. I live with it, I accept that. It's the price you pay for the work. But it never leaves you. And of course, some doctors are very good at completely denying it, completely blocking it off. But in my experience, that's unusual. But nobody other than, in my specialty of a neurosurgeon, only another neurosurgeon understands what it feels like. Non-medical people think, well, doctors, it's their job, they're strong, you know. They don't realize how sad and painful the work can be when we fail, if we're good doctors. If you're a bad doctor and a psychopath, well, then you don't care. Next slide. Very important for sharing experience and learning, particularly, as is now the case in England, the junior doctors have less experience. So it's very important to share your experience. So if you have a rare, unusual problem, you discuss it with your colleagues, and they learn from your experience as well. I discovered many years ago, if I had a very difficult operation to do, which was going to take, 10, 15 hours, something like that, it was much, much better if I did it with another surgeon, with a colleague, and we took it in turns, and you get less tired. And I learned, because I started when I was a young senior doctor, I did some big heroic operations which took me hours and hours and hours, and usually the patients did very badly. And that was partly because I'm not a Superman, and after operating for, let's say, 7 or 8 hours, very intensely, using a microscope, you start getting less good. And certainly in brain surgery, often the most difficult part of the operation is near the end of the operation, when you're operating on the brain stem or the basilar artery or the cranial nerves, something like that. So from many years ago, if I had very large, difficult tumors to operate on, I would share it with a colleague, and we'd do it together, which is actually a very nice way of operating. It's actually more enjoyable, it's less stressful, and yet the patients like it as well. They're quite happy with the idea that 2 people rather than 1 are looking after them. Next slide. We are fallible human beings, and yet our patients want us to be like gods and never make mistakes. And that's difficult. We have to pretend to patients we're better than perhaps we feel we are. But you probably all know this famous experiment where you ask, it's a video which I can't play, you ask people, how many times do the people in white t-shirts pass the ball to another player? And you show this, and this video has been shown to thousands of people all over the world. And in the middle of the video of the people passing the handball between each themselves, a man in a gorilla suit runs into the middle, beats his chest, and then runs off again. 50% of people do not see the gorilla. And that has been repeated time and time again, because we're concentrating on the people in white t-shirts. So if we can make mistakes so easily in something as obvious as that, when we have much, much more complicated, difficult decisions to make as doctors, we are certainly bound to get things wrong. And we have to, the beginning of wisdom is to accept that I make mistakes. And then one can start. Now that, for instance, is an example of the inattentional blindness you saw with the gorilla, but also something called the availability heuristic, which is a long name, but all it means is that, as a surgeon, if you see a patient with a particular problem, if the last patient you operated upon with that problem did very, very well, you probably will be over-optimistic when estimating the risks of operating on this new patient. And if, on the other hand, the last patient you operated upon with this problem did very badly, you probably will overestimate the risks of operating. That was an operation I did for a Chiari malformation, a very nice operation. I'd done probably at least 100 with no serious complications. She went home after 2 days, 3 days, came back a week later, very ill, but I couldn't, ill in a strange way. I thought she was septic, she clearly had some sort of infection, but I couldn't quite understand it. And the scan showed that. It's a bit like the invisible gorilla. Any neurosurgeon will say, look, the cerebellum is squeezing out of the posterior fossa. There's all that black stuff around the brainstem. That is a very rare complication of a post-operative posterior fossa subdural empyema. But even when I looked at that scan, I was so puzzled, I was so worried, I thought I've never had a serious problem with this condition before. I delayed re-exploring the wound, draining the pus by 24 hours, and she was left completely trashed, completely paralyzed and crippled. She is still alive. I told the family to sue me, and I think the settlement was for about $8 million because she was left completely paralyzed. But I find it staggering now, looking at that scan, to think, what? It was obvious, I didn't see it. So it's a useful, and then, it's very important when I teach my juniors about this particular operation to say this can happen. It's very unusual, it's very rare, but unusual things happen. Next slide. That's the WHO checklist. When it was introduced into my hospital about 15, 16 years ago, I was rather angry about it. I said, look, I don't want other people to tell me whether I'm doing the right operation on the correct side. So, I felt this was an insult to me. And then my anaesthetist, who was a good friend, said, well, you did once start an operation on the wrong side. And I thought, so I accepted, although I have some criticisms of the WHO checklist, the principle that you do checklists, you check things beforehand, you don't rush into an operation without careful, methodical preparation, I think is a good one. But the interesting point is the way I was so reluctant to accept it actually would help me. And my pride, my ego was distorting my judgment. Next slide. You should all read this book. There are a lot of medical examples in it, but it's very easy to read. A lot of it is about aviation safety. I used to be rather dismissive, critical of people saying, look, the aviation industry has become fantastically safe, whilst medicine still remains fantastically dangerous. And there are many things that could be done to improve that. And I thought, well, but operating is more complicated than flying an aeroplane. But when you read this book, and Syed talks about several famous aeroplane crashes, what I took away from reading that book is very well-trained, very intelligent, very motivated people can make terrible mistakes. Of course, the difference for aeroplane safety is the pilots usually get killed, so you feel kind of sorry for them. Their mistake has resulted in their death. Whereas if a surgeon makes a terrible mistake and the patient dies, the surgeon lives. And then the surgeon either has to pretend it wasn't his fault, or he just blocks it all off, as many surgeons do, and you say, oh, the operation was a success. The patient died, but that was not my fault. Or you feel terrible about it, and you feel sick with anxiety and miserable, often for many days, as I used to do, but you go on working. But a day never passes in my life, now that I am retired more or less from operating, a day never passes without when I remember patients I feel I failed. It doesn't upset me too much, because I know I helped more patients than I failed. But it's a very important part, I think, of being a doctor, to understand and accept that failure is a very important part of our work. And the challenge is to learn from failure, to admit failure, to accept we are not gods, to learn from our colleagues, and try to make the safety of our patients our first priority, rather than our self-respect and our own ego. Next slide. There are problems, of course, with team working. Next. It's very hard to have an effective team if it's very large, or if the membership keep on turning over. The basis of successful team working is actually friendship. Your colleagues become friends, you treat each other with respect. It's difficult if there are new people in the team all the time. It needs good leadership, because a good team will often argue. A good team there will be tension and disagreement. And it's the duty of the leader to make sure this becomes a positive, constructive process rather than a negative one. Next. And of course there are personal conflicts and jealousy, particularly with surgeons, particularly with Ukrainian surgeons. Next slide. And again, it's very important if you have good team working, but nevertheless, somebody, and it has to be the leader, is still responsible for what happens. It's no good having a team where if the patient comes to harm, nobody says, well, it was nothing to do with me, it was the team, and no individual takes responsibility. So it's very important that as part of a team, there is a clear line of responsibility for what the team does, and that is one of the burdens, one of the difficult things about leadership. Next slide. And again, it's a big problem in America. It's becoming more of a problem in Europe. Because of all the specialization, you have more and more different groups of doctors looking after a single patient. And the patient and the family can end up very confused. Now, who is responsible for me now? And it's a big problem in America, trying to reduce that fragmentation of care. Next. Yep, yeah, come back one. So that is my slide of the surgical ego from Snow White and the Seven Dwarfs. Mirror, mirror on the wall, who is the fairest of them all? All surgeons are always sort of looking over their back a bit, wondering, am I the best? Are some of my colleagues better than I am? And that's a fact of life, but it is threatening to worry that other people might be rather better than you are. You can only do your best, and of course, you have to make a decision if you see a difficult case. Do I lie to the patient and say I am the best person to do it? Or do you say, well, actually, my colleague in another hospital has more experience than me? It can be difficult. The solution, of course, is to ask the better colleague to come and do the operation with you. Teamwork. But not many surgeons do that, or not as many as they should. Next slide. That's an example of another problem of teamwork, which the psychologists call groupthink. But if you have a team where people are more concerned to get on well together and not to argue, they'll sometimes make bad decisions. That was a patient presented with acute hydrocephalus with a very difficult cerebral hemangioblastoma, which are very bloody, difficult tumours right in the foramen magnum, pressing on the brainstem. I had retired by then, but I was still working part-time, and I was acting as a sort of mentor for my trainee who had taken my job. And the case was presented at the weekly surgical meeting, and it was under the care of my colleague, and he said, oh, that's very dangerous. I think the patient ought to have radiotherapy. And I said, well, actually, I think we can do the operation. But he was adamant that no surgery was too dangerous. And I thought, well, that's actually the wrong decision. But I did not want to insult him by saying, look, I'm better than you are. I'm not, but I was more experienced than he was. And I had operated on quite a few tumours like that. But I did not want to cause upset and trouble, and the radiotherapist said, oh, well, we can treat him, although actually it's not the right treatment. And the patient had the radiotherapy treatment. It all went terribly wrong. He ended up having an operation, but he was left completely trashed, as my Americans juniors would call it. But that is an example of groupthink. I was putting the interests of the group and very quiet life ahead of what was really in the interests of the patient. Next slide. So a few painful truths about Ukraine, and you may say I'm very unfair, and all I can say is, look, I keep on coming back, so I do love Ukraine, and if I thought you were all hopeless, I would not be here today. Firstly, you have to remember Ukraine is a very poor country. Yes, I know the official statistics are not accurate, But the same applies to Moldova and Albania, where the official statistics underestimate the true economic activity. But it is the poorest country in Europe, and therefore it means to have a modern, effective healthcare system is really difficult. There's no question of the fact, if you're designing a healthcare system, primary care is actually more important than having lots of hospitals with brain surgeons and lots of clever technical equipment. The basis, the building block of any good healthcare system is a system of good family doctors who know where to send patients. I know one Sapun was trying to change primary care in this country and was called Dr. Death and was very unpopular. But from what I could understand, essentially I felt she was trying to do the right thing, even though it perhaps didn't work. Next slide. Corruption is a problem, as you all know, and yet, as I was telling people in England at a lecture last week about Ukrainian healthcare, the doctors in the government sector clearly cannot survive off their government salary, and they have to have informal co-payments, as you call it, from their patients. The problem with that, of course, is it's not transparent, it's not in the public eye, and this can lead to exploitation, and it clearly is deeply unsatisfactory. And somehow, if you want a good government medical system, you need to pay doctors and nurses reasonably well. And that's difficult in a poor country at war. Next slide. And there are far too many hospitals, probably far too many specialists. This dates back to the Soviet time, when the Soviet Union liked to pretend that everything was as good as the West, so they built lots of hospitals and research institutes, but these really were Potemkin villages and empty. And even though it's now, 32 years since the end of the Soviet Union, your healthcare system still has many vestiges, we call it, many leftovers and remains from the Soviet system. And in a rational healthcare system, you should have fewer hospitals. You cannot have good modern medicine with lots and lots of small hospitals. You are diluting experience, you are duplicating facilities, so it's more expensive, and everybody is less experienced. But I fully understand it's very, very difficult to close hospitals. The patients don't like it. It's strange. Same problem in England, where we've had to close many hospitals. The local patients always say, no, we want our local hospital. Even if you tell them that actually if they travel 30 kilometers, they will get better treatment at a bigger hospital. In Denmark, over the last 10 years, they have reduced the number of hospitals from 82 to 32. On the grounds this is more efficient and will work better. Next slide. There is an underlying problem. All over the world, healthcare costs are going up and up and up. I mean, you can see that is the growth rate, not just the absolute level. That's a long time ago, 1880. Everywhere is shooting up. And almost everywhere, the growth rate of the cost of medicine is growing more quickly than the economy is growing, which means that a larger and larger part of national wealth must be devoted to healthcare. And that, of course, is a very political problem. And the reason for this is very simple. There are more and more older people in the community, and medicine is getting better and better. We have more and more technology, more and more chemotherapy, so there are more and more very expensive things we can do to more and more old people. Next slide, I think the next, no. And this is because that was, this in fact is Britain, that was the English population 40 years ago, quite a lot of young people, and then you get older, it's shaped sort of like a pine tree. In 20, 30 years' time, you'll see it'll be shaped like that. And the proportion of old people in the population will be much higher, and cancer and dementia, which are both very expensive diseases, dementia in terms of care, cancer in terms of all the treatment we can give cancer now, are essentially diseases of old age. By the age of 70, your risk of having cancer is 1,000 times greater than at the age of 20. Although certainly in Britain, all the charities that raise money for cancer research always show pictures of young children and young women who have lost all their hair. But the reality is it's mainly old people, and there are many difficult decisions to make. At what point do you stop treating somebody because they're getting very old? Next slide. And one aspect of that again, you can see there are now fewer and fewer young people to look after the ever-increasing number of old people. And there are many answers to that. In countries like Italy and Japan, in fact, it's predicted the population is going to shrink by 50% by the end of the century, because in most modern countries, women are having fewer and fewer babies for all sorts of reasons. Even in Pakistan, the average number of children per woman is 2, and you need 2.1 babies to keep the population at the same level. And of course another aspect to that in Europe and England is immigration and all the political problems that come with that, and Brexit was partly about that. But again, that's a big problem in healthcare. Next slide. And this is just an example. This is cancer care, cancer drugs in Europe over the last 28 years. And it's gone from 9.5 billion euros to 16.8 because there are more and more cancer drugs. Some of them work very well, some don't. So all this is a very, very difficult cost pressure for the governments trying to run a healthcare service. Next slide. Again, another example of technology. I was talking to my friend who was head of surgery for all of England, for Royal College of Surgeons, and he said robots. Robots are definitely the next big thing. That robots are used routinely now, for instance, for prostate gland surgery, but he said he thinks there'll be many operations. This is robots controlled by human beings. These are not autonomous robots. But they are, of course, terribly expensive. It's about $2 or $3 million for a robot. But that is the next step. So the relentless march of medical technology becoming more and more expensive all the time. And countries like Ukraine must decide, do we need good primary care with good family doctors, or do we need good robots, which are very expensive? There are always trade-offs, as economists call it. Next slide. And as the great, clever American journalist H.L. Mencken said, for every complex problem, there is an answer that is clear, simple, and wrong. And I often think that applies to Ukraine, because I'm always being asked, what would you do to make things better in Ukraine? And I say, well, it's difficult. It is difficult. It's really difficult. And the fact, for instance, Liliana Suprun came into so much criticism was because people, you cannot change these problems quickly. It takes years to make things better. It takes 5 years to make a doctor. It should take another 5 or 6 years to get a good specialist. So changing healthcare takes a very long time. Next slide. But although the English National Health Service is struggling at the moment, because basically it's a lack of money for various reasons, until the Tory Conservative government came into power 12 years ago, it was actually doing very well. It's now doing rather badly in terms of waiting lists and lack of beds, lack of ICU beds, doctors on strike, nurses on strike, never happened before. Many problems. But they'll be solved. I think they'll be solved. But the point is that it really was a child of the Second World War. War is terrible. War brings terrible destruction. But it brings great opportunities to start again anew. And who knows, maybe this terrible war Ukraine is desperately fighting for its survival at the moment. When, I'd like to say we have won the war, or you have won the war, maybe some things can be made new and better than they are at the moment. In fact, it's funnily enough, that's Ernest Bevan, the socialist politician, who was originally a Welsh coal miner, never went to university, left school, I think, at the age of 12, a great man. He created the National Health Service, and it was very, very difficult to persuade the doctors to become employees of the government. They hated the idea. And he managed to persuade them eventually, and he said, I stuffed their mouths with gold. And what he said was, well, if you have a full-time contract with the government, you can then do as much private work as you like in your own time, at weekends or in evenings. And by stuffing the doctors' mouths with gold, they shut up complaining and joined the NHS. And for all the problems of the NHS, it remains very, very popular most of the time in Britain. So perhaps the terrible war we're in at the moment might be an opportunity as well. Is that next slide? Might be the end. No, that's the last slide. So I hope you could follow some of that, and forgive me for being critical of your country, but as I said, I love you all dearly, which is why I keep on coming, even when bombs are falling, you know. I'm very happy to answer any questions if you want. But I'm also very happy not to answer any questions.
Панове, якщо у когось є запитання, піднімайте руки, будемо спілкуватися ще більше.
They're all shy. That's all right. Never mind.
Хто буде першим? У нас є доброволець.
Dr. Marsh, firstly, I'd like to say thank you for the wonderful lecture. And I'd like to ask, when I talk to my British friend and we talk about national health system, they say that they are happy with their doctors, but they are not satisfied with the system.
Yeah.
But from my side, the National Health Service in UK, it's a nanny construction for every person, for every citizen. But when you ask a Ukrainian patient about their experience, they would blame the particular doctor, but not the system, although you think that the system is wrong, but the doctors are not bad. How could you explain this situation? Is it a difference of mentality or situation in economy? Is there a particular reason for this situation? Thank you in advance.
Well, the Ukrainian patients blame the individual doctor rather than the system. You know. It's a difficult question to answer. I'm tempted to feel that it's a rather primitive, ignorant, childish view that every doctor should be perfect. So if things do not work well, therefore it is the doctor's fault. A more educated, sophisticated person would understand it's more complicated than that. But more than that, I can't say. I don't know. But having worked in many countries all over the world, I've learned that on the whole, as patients, when we're ill, when we're sick and frightened and in fear for our lives, we're all the same. We're all human beings. But the relationship between patients and doctors varies a great deal between different countries, depending on different cultures. And sometimes there are great surprises. I've worked a lot in Kathmandu in Nepal, where I went after I stopped working full-time for the National Health Service in England. Now, Nepal is a very, very religious, superstitious society. I mean, very beautiful, although we had a terrible civil war 20 years ago, so there are lots of problems, and it's very corrupt, and it's very poor. But you might think that with a very superstitious people, they would not have problems accepting death and things like that. But I found it really difficult explaining to families when we had patients who were essentially dying from brain problems. They couldn't accept it, you know. I thought, well, surely if it's all religious, things will be okay. No, it was very, very difficult to have a rational conversation about whether to stop treatment or not. I even had patients who were admitted brain dead to the emergency room with fixed dilated pupils, where the family would then go on bagging them and taking them around other hospitals, trying to find a hospital who would agree to treat them. So it's surprising.
Any other questions? Yes. Thank you, Dr. Marsh, for a fantastic talk. So I have a practical question. How you select the interns, or after 2 years of interns, the candidates for specialization? Is there any centralized
Yes, there is. There's a national selection system.
Could you say a few words about that?
Both to work to get your foundation years, your first 2 years as an intern, and then to be accepted into a training program, there is a competitive examination, a lot of which is practical. You have to talk to actors who pretend to be patients, and you're watched doing that, and you have to have some sort of manual tests. And if you do very well, you can then choose which hospital you can work in. If you're lower down the list, you then will be told where you have to go without any choice. But the senior doctors in the hospitals have no say in who comes to work with them. It used to be very different. I would interview my trainees myself, and I would decide who would come and work with me or not. But in recent years, I had no say at all. I hated that in principle, but actually it didn't seem to matter, and the trainees who were sent to work in my department were always very good. But then my department had a very good reputation, so we tended to get the best trainees coming to work with us. There's absolutely no room for pulling strings, you know, ringing up saying, oh, hello, you know, my son or my friend's son is really very nice, and could you find him a job? It's called the old boy network. Hello, old boy. Would you like to have a look at this friend of mine? No, that's absolutely out of the question now.
Наступний.
Professor, hello.
Thank you, Dr. Marsh. Thank you very much for everything, for your help with our difficult patient in our department, for your promising to help in future. And I have a very practical question, and it is will be, I think, will be very important for my young colleagues. The situation is like that. For example, you discovered a mistake of your colleague when you consult the patient. Do you try to hide the mistake of your colleague in front of the patient?
It's very difficult.
Yeah.
It's very, very difficult indeed. We say in English, we all have skeletons in our cupboard. We all have made mistakes, most of which have not come to light. So we are very hesitant to criticize colleagues. But I remember one case with a young woman with a medulloblastoma tumor, a tumor in the cerebellar vermis, who had been operated upon in another hospital. And the operation had gone very badly. It was a very big London hospital, good surgeons, so it was very surprising. And she was then sent for radiotherapy, which was appropriate treatment for a medulloblastoma after surgery. But my radiotherapy colleagues said, Henry, look, there's actually a lot of tumor left behind. It's better to give radiotherapy of all the tumor has been removed. So I took over the patient and operated on her. And it was immediately obvious that whoever had done the operation had made a complete mess of it. They'd gone in too high, they had missed the tumor and actually hit the brainstem, which is a pretty basic mistake to make. And that was why she was left quadriplegic with ocular bobbing movements. It was horrible. And it was totally obvious to me that the operation had been done really badly, and there was really no excuse for it. And even then, it was really, really difficult to sit down with the family and say, look, I think you need to take legal advice about this. Because it's difficult, not just because I hate ratting on my colleagues, but it's devastating for the family. They thought this problem, their poor daughter had been left terribly disabled, and they'd been told the tumor had been removed. In fact, not all the tumor had been removed, and the operation had been done clearly in the wrong way. And it's terrible for them to feel that their daughter's terrible situation was actually unnecessary. So you hesitate, but sometimes you have to. I found it easier when I had bad mistakes to tell the patients myself they should sue me. But that is actually very unusual. Not many people do that. And it is a problem for Ukraine. Are you going to have a lot of medical malpractice, negligence litigation? It's good for the lawyers. In England, a lot of money now is spent by the government because of patients suing, taking legal action against hospitals and doctors. And I saw a quite extraordinary statistic last week that the biggest financial cases are when people are left alive but very disabled. So when a neurosurgeon damages a patient and you can prove in court it was the fault of the neurosurgeon, we're talking about maybe 40 or 50 years of care and disability. So that's millions of pounds, like in my case I told you about. But the other area, of course, is obstetrics and babies. And if you miss fetal distress, if you bungle a breech delivery, things like that, you're then talking about 50, 60 or 70 years of damage. And then you have these huge awards of millions of dollars. And in Britain now, last year, the National Health Service spent more than twice as much on legal expenses for mothers and families suing over badly managed obstetrics than they actually spend on obstetrics. I mean, it's crazy, absolutely crazy. So how you'll solve that problem, I don't know. But it is, doctors should be sued. I mean, they should be answerable. And one of the great problems you have is you still have a legacy of the Soviet system where doctors were gods. You could not complain, you could not sue doctors, and doctors had absolute power. And absolute power corrupts. And that is changing a little, but there are lots of problems. So although it is a good thing that patients can complain and can take legal action, there are many bad aspects to it as well. And there are some countries like Sweden and New Zealand where there is automatic state insurance against medical errors, and there is no litigation at all. So the lawyers do not make lots of money from this.
Okay, we've got another question here. Mr. Marsh, thank you for one more brilliant lecture. I want to ask you, imagine that you are a young doctor,
yes,
maybe intern in Ukraine, and you understand that your chief, senior doctor, is less qualified than you,
yes,
and making lots of mistakes.
Yes.
What would you do
with the junior
in
doctor?
such situation?
No good. I thought it was usually the other way around in Ukraine. The junior doctors are better and the old professors are.
That's what I'm talking about. Imagine that you are a young doctor and you're chief.
Yeah.
Yes.
It's very difficult. It's very difficult is the answer. There was a patient here in Ukraine many years ago with a fourth ventricular ependymoma, very difficult case. And she came to see me when I was working with Kurelitz years ago. And in fact, I told her to come to London, and I operated on her. In fact, in those days, the National Health Service was very generous, and we were able to treat her free of charge. And she actually went, and she lived in Kherson. I don't know what's happened to her now, but the operation went okay. But the doctors in Kurelitz's clinic told me that she had been to another famous neurosurgeon in Kiev, and they'd said to her, if you want to live, go and see Kurelitz, because he has contacts with Western neurosurgeons. So if it's that bad, the junior doctors perhaps need to whisper in the patient's ears they should go somewhere else. But it's a very difficult problem, and I'm told that here many of the senior doctors don't speak English, they're not up to date with the professional literature, and of course English is the lingua franca, the international language of medicine. So we end up with a difficult situation where the young doctors often feel they actually know rather more about recent research and progress. That will take a long time to change. You have to wait for the old doctors to retire, or die, but you can't get rid of them. But it's difficult. All these problems are really difficult. As I said, no simple answers.
Any other questions? Okay, while people are thinking on the questions, I'll take the advantage of possessing the microphone and ask a question myself. We've got here a lot of our interns, our trainees, which we admire, but we also have here today our mentors, the doctors that actually train our interns. And my question is, what do you think is the ratio between the mentor's responsibility and mentee's responsibility for the result, for their education? Who is more responsible for the education, the intern himself or herself?
It's 50-50. I mean, you have to, as a senior doctor, in principle, I think almost all doctors in Britain would say this. We have a moral duty to the patient in front of us, but we also have a moral duty to our trainees' future patients. So for most surgeons in England, there are always exceptions, operating and training go together. You're always, every time you operate, you're usually training as well. But at the same time, the trainee has to work hard and read the literature, and so it's not all up to the senior. So it's a bit of both. It's a bit of both. I will ask myself a question. I'm often said, what advice would you give to a young doctor? One simple piece of advice, and the answer actually is very, very simple, is ask for help. I trained in a system where you did not ask for help, and you thought you were a bit feeble, a bit of a sissy if you rang up your boss at 2 in the morning and said, I'm terribly sorry, sir, I've got stuck, I don't know what to do. And you were kind of expected just to carry on, even if you'd only seen the operation a few times. And I can think of several patients who came to terrible harm at my hands because I went on operating when I should have stopped and I should have asked for help. It is better now in Britain. There is more supervision of the young doctors. But the point is, as I was saying earlier, if you accept you can make mistakes, just as we all, 50% of us do with the gorilla, it's easier to ask for help. I trained many neurosurgeons from many countries, particularly America, who came to work with me in London. And I learned very quickly the ones I did not trust and the ones who had problems and caused problems for me were the ones who were very self-confident. I preferred my trainees to be keen, enthusiastic, but always a bit anxious, and to understand their own limitations and ask for help. So ask for help, and it's a sign of strength to ask for help. To not ask for help is a sign of weakness. You do not dare to admit but actually I don't know. I'm not perfect.
Thank you. And this is the last call. We've got time for one more question and then another guest star.
Okay, thank you again for your great lecture. I would like to ask you about teamwork and how to build a team from the scratch. For example, you have like 3 or 5 different people, different doctors. Some of them are motivated, some of them less motivated but also capable, and some of them simply don't care and then just want to make money from the air. Like, how to make them all work together for the greater goal? Is there a simple solution or there is difficult?
It's not easy.
Thank you.
You need good leadership. A team, you will never create a good team if you don't have good leadership. And as that slide I showed you earlier, a good leader is supporting rather than shitting on the members of a team. You have to be a good colleague yourself. If you're not a good colleague yourself, you'll never have good colleagues. And to be a good colleague means to treat people with respect and listen to them and treat them with respect as you would wish to be treated yourself. And it takes time. It takes time to build up a team, and people who are not suited to it will leave, other people will come. But there's no quick, easy solution to it.
Thank you, Dr. Marsh. Sorry for my speaking Ukrainian. У нас, як у кожного порядного шоу, є своя гест-стар, неочікувана гостя зіркова. Я хочу її представити. Перед цим декілька слів. Багато з вас молоді лікарі, це дуже класно, ви дуже амбітні, це також дуже класно. І, можливо, більшість з вас хотіла би, скажімо, реалізувати і продовжити свою кар'єру десь за кордоном, в більш розвинутій медичній системі, в більш розвиненій цивілізованій країні. В цьому немає нічого поганого. Це чудово і, можливо, комусь із вас удасться. Але недавно зустрічався зі своїм колегою, який був власником дуже успішного бізнесу. Але я дізнався, що 25 лютого він закрив всю свою клініку, тому що він прийшов на роботу із 35 людей у Львові, вийшло на роботу 7. А він був медиком протягом року на передовій, зараз повернувся у відпустку. І сказав, що багато його підлеглих втекло, хто в Австралію, хто в Польщу, хто в Нову Зеландію, хто в Америку. Він же ж власник бізнесу, да, і успішний доктор, успішний бізнесмен пішов воювати. Тобто вектори інших різних людей несподівані. Хтось тікає з цієї країни навіть зараз, так? Навіть з західних регіонів України. А хтось вертається. Я хочу представити нашу гостю, яка зробила нам велику честь, доктора Ірину Рубінкіну, яка є консультант-анестетист в NHS, яка працювала довгі роки, яка киянка з Позняків, яка зробила чудову медичну кар'єру в Великобританії, працювала в Brighton University Clinic as a consultant-anesthetist, яка має гарного чоловіка і 2 чудових дітей, яка вирішила їх ростити в Новій Зеландії, знайшла місце роботи в Новій Зеландії, купили вони будинок. Як тільки вони купили будинок, Іра дізналася, що в Україні війна. Іра звільнилася з роботи, продала будинок і тепер живе між Британією, Голландією, Україною, відкрила свій власний фонд і працює на нашу перемогу. В той час, коли ми зустрілися з нею черговий раз у Львові 5 днів назад, і вона мені сказала, що її чоловік Яко і 2 маленьких діточок Олександра і Деніел ось-ось приїжджають в Україну. Тобто в той час, коли одні люди тікають, другі приїжджають в Україну і привозять свої сім'ї for holiday, як ми пожартували. І Рубінкіна прошу зустріти.
Дякую, Андрій. Ну так, і вони проспали вчора всю атаку дронів і ні разу не прокинулися. Добрий день всім, дякую, що запросили. Я тут і залишуся, мабуть. Мені всіх видно і всім мене видно. Так, я взагалі випускниця Національного медичного університету у 2004 році, і вся моя postgraduate education взагалі була в Великобританії. Все дуже змінилося за 21 рік моєї кар'єри в Великобританії. Навіть
іспити, які я здавала 20 років тому, і ті помінялися. Але це шлях, який багато лікарів, які виїжджає. І я завжди була патріоткою України, але в Україні мені не дали працювати. В мій перший день на роботі мені сказали, що хірургом я буду через чийсь труп. І мені був 21 рік, і я просто вирішила, що я так не хочу. Що стосується postgraduate education, воно відрізняється. І доктор Марш, він сказав багато різного і багато чого можна вводити в Україну. І ми з 2014 року я працюю над різними проєктами, наприклад, ОСКІ, який читає і які проводять для анестезіологів Шубика, це написала зробила я і ввела в роботу, і зараз воно активно практикується. Тобто шлях, наприклад, будь-якого спеціаліста в Великобританії, він дуже довгий. Він не 2 і не 3 роки, а 10. 11. І ми всі відтягуємо той момент, коли ми стаємо консультантами. І коли я комусь кажу, що таке консультант, на мене дивляться, кажуть, а ви взагалі лікар? Я кажу, ні, я консультант. А ви лікар? Я лікар, да, але консультант – це найвища ступінь лікаря, наприклад, в Великобританії, тобто коли ти вже можеш сам за себе відповідати. І у нас в Великобританії немає як такого завідуючого відділення. Є людина, яка займається адміністративною роботою, і всі дуже це не люблять, і завжди завідуючий – це той, хто витягнув short straw, да? Тому що з вашої роботи у вас ще є вся адміністративна робота, і вас дуже не люблять, тому відпустку не дали, коли хочеться, тому часи якісь, тому операційну поміняли, і всі вас ненавидять. Да? Тобто тут досить інша роль. А так ми взагалі працюємо всі на рівні. І, якщо чесно, хотілося б менше мені говорити, більше вас послухати, або, може, у вас є якісь специфічні запитання, тому що за 20 років кар'єри я стала хірургом, а коли стала хірургом, я зрозуміла, що я не хочу бути хірургом. Я здала всі іспити, а потім мій консультант зламав руку, у мене вже мені залишалося 2 роки до консультанта, і я 3 місяці робила його роботу, і я вирішила, що я не хочу такого життя. І мені захотілося перекваліфікуватися. І, якщо чесно, ніколи не дивилася назад. І наступні 10 років я навчалася на анестезіолога. Тому анестезіолог – це таке, ми знаємо все про все і вся в Великобританії. Коли ти випускаєшся анестезіологом, ти можеш анестезіювати все. Мені цього теж не було недостатньо, тому я вирішила до топ стати кардіоторакальним анестезіологом. Тому що я люблю свою таку nerdy операційну з 30 машинами, яку роблять біп-біп, і ще така можливість саме тримати життя людини в своїх руках. Тому що все залежить, як би там хірурги не казали, все залежить від анестезіолога. Тому, Андрію, так. Не посміхайся так. Тому що саме цікавить. І, якщо чесно, тому ми можемо поспілкуватися і в майбутньому щось конкретно, тобто лекцію по як проходять іспити, як проходить інтернатура, як проходять, не знаю, навчання. Якщо це цікаво, я в Києві іноді залітаю між передовою, Львовом і Великобританією, Ірландією і всіми іншими країнами. Тобто я зможу зупинитися.
Я дуже дякую, що ви прийшли до нас. А таке питання. Ось ви приїхали з Києва до Лондону. І що? Куди ви пішли з вашим дипломом з богомольця, і що ви сказали? І що вам запропонували у відповідь на те, що вони побачили наш диплом?
Ви знаєте, я тоді взагалі не розуміла, що відбувається. Довелося, по-перше, здавати англійську мову. І І цей іспит ПЛАБ в Великобританії, ну не ПЛАБ, а іспит IELTS, який ми здавали, він був достатньо складний, але мені він просто дався, там на високий бал. Потім довелося ще чекати, але чому саме Великобританія? Я б з'їздила в своїй, ну коли була медичною студенткою, я займалася міжнародними відносинами і така організація International Federation of Medical Students Associations, я її головою була, я її саме привезла в Україну. То я об'їхала всі країни і ну, знала трошечки англійську мову. А коли от таке на роботі сталося, я просто прийшла до батьків, взяла квиток в один кінець, тому що ще на 3-му курсі я була в Великобританії і я прийшла просто в лікарню і сказала, я хочу подивитися, як у вас тут є. На рецепції сиділа жіночка, вона на мене дивилася навіженими очима, але дала мені телефони декількох консультантів. Я до них прийшла, там сиділа секретарка, сказала, да-да-да. І я 2 тижні ходила з одним з них. І йому так сподобалося там те, що я казала, не знаю, взагалі, як я його була хвостиком, він сказав, приїжджай на науку. І от туди я і приїхала, коли мені показали на двері. Наш диплом нічого не значив, насправді. Довелося перескладати все. Плат 1, плат 2, да, це великі іспити, до яких я не була підготовлена, тому що тоді крок тільки перший рік був, чи починався, чи щось таке. Там були саме плат 1, це SBAs, Short Best Answer, і це MCQs. Зараз воно більше, ми переробляємо всю систему, тому що я також, я є і викладачем в університеті, я працюю багато, у мене Masters in Simulation and Clinical Education, тобто дуже багато різних титулів, і я займаюся саме освітою, так і своєю клінічною роботою. І ось саме до тих іспитів я не була готова, і я його провалила 2 рази. І тільки на 3-й я зрозуміла, як його складати, і склала. А після того був ще один іспит, який називався ОСКІ, який було 12 станцій, і теж було все не так, як у нас. Тобто своя маневризм спілкування з пацієнтами, як доктор Марш казав, досить по-іншому, своя оцінка, свої протоколи, все це треба було вивчити, і все це треба було пройти. Ну і, якщо чесно, коли я це прийшла, ще в мене була українська, я була українкою, у мене був український паспорт, тому мені не хотіли давати роботу. Десь 1,5 року я працювала як research assistant, і тільки тому, що мої консультанти дійсно put their foot down, мені дали місце інтерна 2-го року, foundation year 2. І дивлячись, якщо чесно, назад, дивлячись на цей мій перший рік як лікаря в Великобританії, я не знаю, як мої пацієнти вижили. Тому що моя робота, вона була в тому, щоб написати папери, робити аналізи крові, ставити канюлас, все інше, які я ніколи в Україні не робила. Тобто я до цього була зовсім не підготовлена. І повністю вести лист, тобто вся paperwork, я була секретаркою свого консультанта, я вела всіх пацієнтів його, я знала його клініки, і також я кларкінг, тобто я приймала пацієнтів. Це значить, ти ставиш канюлу, робиш бладс, робиш всі діло, і ніхто з медсестер цього робити не буде. Це робота junior doctor. Сечові катетери, внутрішньовенні катетери, всі процедури, це робота junior doctor. Це твій перший рік рабства, як називається. От це ти робиш. І мені, це був мій eye-opening experience, тому що до цього я 1,5 року асистувала в операційній з моїм научним керівником вже в Великобританії, і після цього я просто спустилася до самого bottom line. Але от, якщо б я так не зробила, в Великобританії я б не змогла працювати. Тому що, розуміючи систему з самого низу і ідучи цим шляхом до SHO, до registrar, first year, second year, ви набираєтеся досвідом. І ви набираєтеся унікальним досвідом праці в різних лікарнях. Я лікарню міняла в перший рік кожні 4 місяці, потім кожні 6 місяців, але я пропрацювала десь в 27 лікарнях Великобританії, в найбільших trauma centers в Лондоні, ти міг поїхати в будь-яку лікарню, але ти не міг залишитися в одній лікарні більш там на 6 місяців або на рік. Тому що це було неможливо, тому що ти мав прийти в іншу лікарню, щоб зрозуміти, який ще у кого досвід, і тільки після того, як твоя кар'єра тренінгова закінчується, ти стаєш консультантом, тоді ти вибираєш собі лікарню, приходиш інтерв'ю. Але це був дуже важкий шлях от самого такого розуміння, і іспити дуже дорогі. Вони так теж не дуже дешеві.
Я правильно розумію, що функціональні обов'язки молодших лікарів, вони прописані, формалізовані, і вони є. І чи можете ви з нами поділитися?
Так, у мене все це є, в методичках, воно все прописано, воно все стандартизовано, і всі асесменти стандартизовані. Тобто зрозуміло, скільки яких треба зробити там кексів, case-based discussion, DOPS, щоб пройти той рік.
Дякую. Чи є ще в когось питання? Користуйтесь нагодою. Добре, тоді дуже дякую вам, Ірино, за те, що ви до нас приїхали. Сподіваюся, це не остання наша спільна зустріч. Дякую вам всім, що ви прийшли. Назад до роботи.
І я б хотіла сказати, якщо наш благодійний фонд Smart Medical Aid, якщо ви хочете ще і з нами поволонтерити, то у нас дуже багато різних програм. І там ми їх вчимо. У нас постійно приїжджають іноземні спеціалісти, які вчать з вами всякі курси. Тому, якщо цікаво, звертайтеся.
Всі контакти будуть в коментарях під відео.